Wonderful. Thank you very much for inviting me to share this study. It's at this stage, it's emerging findings. This is a 3-year study which ends at the end of this month, which was termed Opening the Too Difficult Box, funded by the School for Social Care Research and with a fantastic team that I'm presenting on behalf of, including lived experience and expert practitioner experience, as well as researchers across different universities. And of course, a disclaimer, this is what we have to say. This is not necessarily what our commissioners and funders would have to say. So I just want to gallop through the context because I've crammed in a vast amount of findings and lots of quotes. But where we were at the outset of this study, and frankly, where we still are now, is that the age of death for people who are homeless, and this isn't just people on the streets, this is people in emergency and hostile settings, is very, very young. It's early to mid 40s. It's lower than any life expectancy of any country in the world. And the CARE Act, and as Nicole, my colleague earlier mentioned, the guidance to the CARE Act had brought self-neglect inside the category of abuses and neglect that should be considered under adult safeguarding responsibilities. So the study wanted to know, well, has it worked? Since the CARE Act, has it worked, and is self-neglect for this very, very at-risk and vulnerable population being responded to by safeguarding? There was no research that had taken place, but what we did have was a growing body of evidence from safeguarding adult reviews, and where people had died experiencing homelessness, those reviews said there had been a lack of safeguarding or a failure of safeguarding. So we aim to explore this area, looking not just at homelessness, but at the intersection of other forms of social exclusion. So we term that multiple exclusion homelessness, which I will just define a bit more. But crucially, what happened was our focus was on strengthening safeguarding responses. And we quickly found that we had to widen our scope because people said very little is happening in this realm. And actually, a lot of what might be termed safeguarding was happening in alternative risk management forums outside formal adult safeguarding. And very quickly, I came to see that these were sort of emergency buttons that I saw as slamming your hand on the emergency button on the wall. And in fact, what people were talking about is attempts to really conduct day-to-day multidisciplinary practice, failing and therefore resorting in safeguarding. So the scope really was expanding over the course of the study, and I've presented the findings under those 3 categories. So just in case you don't know what multiple exclusion homelessness, it's really something that was termed by Fitzpatrick and colleagues, and there's a very good reference there, but we're talking about the overlap of institutional care and substance use and street culture. We're talking about an exceptionally vulnerable subgroup, and there are factors and risks that not only might lead you to get to homelessness, but would actually prevent you from escaping from it. And things like adverse childhood experiences and trauma and mental illness are really key here. And because of those, we're often talking about service mistrust and people not seeking or accepting help. So it becomes even more important and poignant if services are not stepping up in this area. So what did we do? After literature, policy, scoping reviews, we had our primary data collection, which is interviews across a wide range of professional groups, and also interviews and focus groups with people who were what you would define as currently still experiencing multiple exclusion homelessness. We were going into day centers, also focus groups of people who perhaps were further on a journey out the other side and were able to engage over a series of meetings over a series of time, some observation. We held community of practice in each of our study sites, and we've reported on those. And we also did, very similar to Nicole's study presented earlier, we did an economic analysis led by my colleague Michaela Tonelli at the LSE. And I'm not really reporting on that here, but she did a full webinar on that. So there's a link with some really thorough findings. So what did we find from our predominantly from our stakeholder interviews? If you focus in the first area on safeguarding, What we broadly found is that safeguarding is, as those SARS had found, not working for this population, that putting in referrals could be seen as just going through the motions, covering your back. There could be no response received, slow responses. Things rarely ever progress to a Section 42 investigation, and this could be incredibly demoralizing and time consuming for practitioners who might actually stop making those referrals. So what were the barriers that were emerging? Why was this? And a very clear one was that it was uncertain if homelessness really fitted under safeguarding. Again, I'm just going to dash through these quotes, but there were a lot of reports of saying 9 times out of 10, nothing's going to happen, not going to Section 42. They've left that risk because that person is difficult. Safeguarding doesn't go anywhere. Or a response, we don't accept safeguarding referrals for individuals who are off sleeping. And this issue about the fit also extended to the idea that despite the complexity of multiple exclusion homelessness, people were seeing an individual's needs as sequential. And housing was always going to be the top of that list as a primary need. So even if somebody is clearly a danger to themselves, they're self-neglecting, they're cycling through A&E repeatedly, they've been referred to housing because that is the primary need. So what we also found is, obviously, well, it may not be obvious, but adult safeguarding falls within a local authority. It falls within the responsibility of adult social care. But there was ambiguity about whether homelessness also fitted under the wide umbrella of social care. And that staff within adult social care and safeguarding teams therefore might not have the understanding, the skills, the insights, and be able to appropriately address the complexity that they would encounter if they came across multiple exclusion homelessness. They might not understand why somebody would reject support, and they may not actually explore whether somebody had care needs. And so, as the first quote says, you know, a social work assistant actually might make a phone call. Well, this particular quote is a phone call to somebody who's living on the streets, a man with incontinence who might be called up, the further details of this quote say, by a young girl saying, oh, I hear you have incontinence. Do you need any help? And immediately the answer would be, no, I'm fine. Okay, I'll close that. And so you have this incredible frustration of workers who are doing outreach saying, no, we need a full assessment, face-to-face, in detail, over time, building trust by somebody who's qualified in this field. And the other accusation really was that it was too easy for professionals to say, well, they've made a choice. This is a lifestyle choice, or we can't go out to the streets. We don't do assessments on the streets. They've told us to go away. So this is non-engagement, whereas in this particular social worker says, I probably keep cases open that I shouldn't. And she was holding extra cases under the desk that people didn't know about because she didn't want to close them. So referrals to safeguarding were often triggered by inaccessible services, gaps in provision. And this would also create enormous frustration, not just from the people putting the referrals in, but of course from the safeguarding staff who were on the receipt of those referrals, because they were saying, what can we offer? We don't have a service for that. And, you know, somebody reflected, look, there's a very high likelihood that somebody would fall under the Care Act. And it's not just that adult social care is saying, oh, they're homeless, they're not our problem. But I don't think it's just apathy. There's knowledge there isn't much we can offer. And therefore, there's potentially a preemptive movement to say, well, we won't accept this referral and we won't investigate further because we know we have nothing to give this individual. So, you know, we raise this concern. How do we map those service gaps, those commissioning gaps, if we're anticipating as a lack of support, and so we're not actually carrying out the assessments that would identify those needs and those unmet needs? So that all sounds like doom and gloom, but of course there's a wealth of positive practice out there. It's often localized, it's often led by very, very passionate individuals rather than being systematic. But of course, research like this tends to find those people because you get referred to the people who are doing interesting, innovative work. And people would describe how they had a bit of a passion, although in other areas might not hit their radar because they wouldn't see it as their issue, or a manager would say that they allow their staff to keep chipping away at cases and work in a slightly different way rather than working in a prescribed way, and they would cover their staff and tell lies to senior management. And again, another positive sign was a broadening, that even over the 3.5 years of the study, there's been a sense that perhaps this population is coming more under the umbrella of social work and safeguarding. So in terms of successes, there's the clear example of homelessness social workers in outreach. This is a really crucial role because they're supporting safeguarding and Care Act assessments. They're offering earlier advice and intervention so they can reduce crises, they can reduce inappropriate and repeat referrals. And it's a very difficult but vital role. It's rare, it's often short-term at the moment, and it's not usually funded by adult social care. And it's something, I think one of the key messages from this study is this is something that needs to be embedded long-term. And there was a lot of evidence that where this role existed, things had really improved. And there's a couple of references here. We did a whole seminar on this back in October, if you're interested more. And I'm also doing a bit of follow-up added value focusing on this role. So there are some references to follow up after if you're interested. But what about outside formal adult safeguarding? Well, what we found is that people said, well, very little goes to safeguarding. Most of it gets sent to the multiple and often overlapping alternative risk management processes that were in place: panels, arms, VARMs, MASHs. And why it would be diverted from one to another was sometimes a little bit opaque. Because safeguarding wasn't suitable, or people cited capacity or consent or a case being stuck, and there could be confusion. Were these for case management, ongoing, or crisis management? And there are a few very creative and powerful panels where senior people kind of cut through the funding blocks and service silo blocks and really do very creative things. But the concerns that emerged here when we were looking at risk management outside adult safeguarding was just there wasn't always transparency about what was the pathway where you chose one process, not another one. And if you've got two processes, somebody could fall between them. And another concern was adult safeguarding was invented for a reason, because it offers leadership and infrastructure, statutory ownership, governance oversight, national scrutiny. And a lot of these alternative forums did not offer that. So somebody, say, for example, you know, they were the probation manager saying in their area, everything gets routed to a risk system. And although it's very laudable, actually there's no oversight, there's no coordination, there's no checking, there's no follow-up of actions. So there were examples of really good ongoing risk management happening for this client group, bringing all of the right disciplines together regularly. But it was still questioned that this was happening outside of safeguarding. And so it wasn't actually enshrined in legislation. This could be fantastic work, but didn't give it the overall governance and scrutiny that it might deserve. Now, I know this is very crammed and you can read these quotes at a later date, but what some points emerge is it can be irrelevant where this process is being carried out if this process of risk management, where people are experiencing enormous risk of harm, if this process is being carried out, there were some key quality standards. And one of the ongoing concerns is that relationships can be very antagonistic between different services and organizations, and that collaboration, attempts to work in a multidisciplinary way, can be experienced as a handoff, trying to hand off a case rather than sharing the risk. Another concern was, again, whatever the model of risk management, that the individual workers who are case managing it could feel more scrutinized than they could feel supported. And that would lead people, where they had an option, not to pursue a broader risk management option. And the last one was really that there seems to be very little experience of pursuing difficult cases like this to their ultimate legal ends, which might be taking them to a court of protection. That there wasn't a lot of confidence and experience of legal interventions. And as this last interview participant said, what we wanted was call to protection, that sort of response, the coordination of all that coming together, but the response is so consistent, and some local authorities would never envisage the idea. We've built up cultures of wanting to say this person is choosing to live like this, it's not our responsibility. So in terms of day-to-day approaches, really these challenges won't be a surprise. I mean, multiple exclusion homelessness by definition is multifaceted and risky. So the structural barrier to working effectively day to day was about working across service silos. And often, as mentioned, that could be antagonistically to protect very, very limited resources that, of course, all services are failing. So safeguarding is often used as a mechanism to complain, to try and address those gaps and those stalemates in services. We know that somebody's going to be evicted. All the services have known that. Nothing's happened because it's just been a lot of people pointing at each other saying, oh, it's your responsibility, until one service says, this is ridiculous, this is a safeguarding concern. And people did report successful day-to-day collaboration in complex cases. And often it was the calling on a large budget would prevent this happening. But again, this sort of working was often dependent on individuals building up really effective networks across different services and disciplines, rather than being systematic, rather than being built into the system. Otherwise, as the manager said, it's very difficult. So people were less likely to receive support because non-specialist services were very clearly inflexible in their service models day to day, and often were described as being discriminatory. And these would be some of the key challenges to day-to-day working with this client group. And because of this, what was very clear is that people describing these gaps in day-to-day working are contributing to a cycle of emergency contact use. People are cycling through expensive and busy A&E services. Safeguarding referrals were being submitted repeatedly. And even if somebody was supported and housed, they would often end up back on the street because they hadn't had the correct ongoing support. So there were good practice examples. I think this is something that is vital, but is perhaps beginning to emerge. Multidisciplinary teams that include all of the required disciplines to address multiple exclusion homelessness, working with a shared vision, trauma-informed, and often developed because of local deaths, or learning from safeguarding adult reviews. So I just shoved in one slide on the lived experience perspectives because we're doing a whole webinar on this next month. But there was a really important point to make, which is that individuals talked about how they were rejecting offer support, of social care and safeguarding support. And they described some of the factors, and that could be distrust of services, addiction, bravado, despair. And there are some quotes there where people talk about all the reasons why they might actually refuse any kind of support that's offered when they're in very risky situations. But what we found in the research is that services are still talking about individuals making choices and taking unwise decisions. And those could be reasons not to pursue safeguarding of somebody. And it seems to me that this is incredibly unhelpful when those people with lived experience are describing situations that really don't sound like conscious decision-making and choice. They described how they might reject those offers of support in crisis, but also with hindsight and in reflection in our interviews, they also were grateful when somebody had intervened, and actually they reflected that they were perplexed when nothing had taken place. So summing up, I haven't got long to go. As I've said, broadly adult safeguarding and the alternative models that are often used in its place are really inaccessible or ineffective for this group. And there are attitudes and gaps and barriers in the systems that are contributing to failures to really respond to the complexity of multiple exclusion homelessness, whether it's through safeguarding or day-to-day responses. And although I haven't really covered the economic analysis at all, a clear message you'll see from Michaela's presentation was that when she did comparative analysis of SARS, of what people had experienced and what they might have experienced if they'd had timely, effective support, that in 2 out of 3 cases, there could have been significant cost savings. And importantly, not just financial costs, but they could have been less calls on emergency services, such as A&E, and instead it could have been a deflection of resources to elective healthcare and, importantly, adult social care support. So a reminder that safeguarding is not supposed to be a substitute for safe and high quality care and support. But what we found is that when an adult safeguarding referral might really be required because of extreme or sudden risks to an individual, where one needed that red button, emergency button press, when you need an urgent injection of local authority led support, because often these cases are being managed from the voluntary sector. When you need that multidisciplinary input and risk management, those referrals were getting lost. They were getting lost because there's an overload of referrals that are simply attempts to highlight gaps in everyday support. So I feel the policy direction is positive. Throughout last year, lots of documents came out, and these are all hyperlinks if you get the presentation. It feels that within homelessness, there is that homelessness is featuring more in thinking and policy guidance on safeguarding and social work. And again, within homelessness guidance, there is much more of a feature of the things that we're calling for in this research: multidisciplinary teams, specialist social worker roles, and more governance and scrutiny. So a last slide then. I mean, how do we address this reluctance to accept adult safeguarding when there are very high risks for individuals self-neglecting due to multiple exclusion homelessness? I mean, one of the key areas is that there is ambiguity in the Care Act guidance that brought self-neglect under the umbrella of safeguarding, and that ambiguity was really clearly reflected in the attitudes of the people, of the social workers and safeguarding leads and managers that we interviewed. There's also a need to address the interpretation, I'm being polite here, the interpretation of safeguarding duty thresholds, because there was a lot of erroneous statements about why people would not be eligible for safeguarding based on whether or not they were perceived to have care or support needs, because they used substances, because they didn't have ordinary residence, because they were homeless, because they weren't engaging, giving consent, issues of mental capacity and immigration. And really, we must emphasize none of these issues are relevant to adult safeguarding, but all of these issues were raised as reasons not to pursue adult safeguarding. So really there needs to be a spotlight shone on this. And a last point really is just, there was a repeated frustration often, well, safeguarding, we're not a service, we cannot offer anything new. But I think to re-emphasize that safeguarding brings a statutory ownership of risk, it brings timely multidisciplinary risk management, data sharing, and commitment from services who often will not collaborate around the table. It brings oversight and it brings national reporting. And these are the forms of scrutiny that we feel are currently lacking for this service user and client group. And this scrutiny could inform improvements to day-to-day practice and commissioning. So thank you very much. There's the website. We've got this webinar coming up and loads of other events. And thank you to our research participants as well.
Thank you, Jess. That was great. Really, really interesting. So I don't know if we have any questions for Jess. I think we've probably got 5-6 minutes or so that we can do. Sam, do you want to? Yes.
Hiya. Thanks for that. That was really interesting. Yeah. So hi. I'm Sam Rickman. I'm a researcher at LSE, but before that, I was a social worker and I managed social work teams, and also before that worked with rough sleepers. So I did feel the both sides of this, sort of the frustration. Yeah, working with rough sleepers, that you would sort of, there's nothing we can do, and why don't they pick it up as safeguarding? But then, sort of within local authorities, I suppose I am sympathetic, because I suppose the way that, you've talked about, or you called it the sort of the poor interpretation of safeguarding or something like that. But I think the thing is, but essentially, you know, if an individual is a rough sleeper, if they're a single homeless person who's not eligible for housing under the Housing Act, then that means they're not in priority need for housing, and that means that essentially they don't have care and support needs. Otherwise they would be in priority need, because that's what part 7 says. It says, you know, essentially the definition of priority need is, I mean, the definition is pretty much the same as the National Assistance Act rather than the Care Act. But it is, it's not necessarily the case that a person who is a rough sleeper doesn't have care and support needs, but a lot of the time they won't have care and support needs according to the Statutory Care Act threshold. And then the problem is then essentially, you know, section 42 of the Care Act, the safeguarding section, says to qualify for safeguarding, you need to have care and support needs and also have the other things, self-neglect or some other type of abuse. So I guess what I'm wondering is, are you saying that you think that the definition should be widened, or are you saying you think that I'm wrong about this and that's not what it says?
No, I think you're right about what it says. What I would say is that what was happening is that often assessments for care and support needs were not actually being carried out. So there was no way of knowing if that person had care and support needs. And that threshold that I mentioned is very low. You don't have to know somebody has care and support needs. You don't have to be meeting their needs in order to initiate some form of safeguarding inquiries. There just has to be some suspicion, I can't remember the terms, that they might have those needs. Now, if somebody is, you know, refusing to go in from the streets and it's -2 and they're at risk of hypothermia, or they're choosing to prioritize class A drugs over nutrition, they're refusing to get emergency healthcare support for an open wound or something, then what we're seeing is incredibly vulnerable people. But those people weren't getting their care and support needs assessed, and therefore there was a presumption. There was often a presumption of capacity without a capacity assessment, and there was also often a presumption that because they were making choices and unwise decisions, they didn't have care and support needs. Because what was often said is, well, you know, if somebody stops drinking and stops using those drugs, then those needs would go away. I mean, obviously, if you stop drinking, using your drugs, well, then you'd eat something. And so you're caught in a catch-22, because those presumptions meant they weren't taking into account, you know, ability to control impulses, which means that people die of hypothermia and they die malnourished and they die of perfectly treatable medical conditions. It also meant that again, that threshold, as you rightly said, of health and social care, that threshold really is just to bring people into the purview of safeguarding. And once they were onto safeguarding, it wasn't necessarily that people needed a social worker, but possibly people did need mental health support for incredible mental health crises. And because there wasn't another mechanism to get that, you know, safeguarding might have been the route to draw in those other services. There often wasn't, or there isn't, adequate data sharing. And again, safeguarding is the model, not necessarily to offer a new service, but the model to get all of the relevant disciplines around the table, talking, collaborating, data sharing on a situation. So that's what I meant about, you know, the thresholds. It would be impossible to say if people had care and support needs, because often the initial assessment would be a phone call to somebody, and therefore there wouldn't have been any way to determine that, particularly for not for this client group.
Yeah, no, it's an interesting one. I mean, I think you're right when you say that, you know, I mean, you said something like that there's a perception that safeguarding is not a service, which it isn't. And I think that is, in a sense, why, you know, there is, if there's a case that's sort of a borderline case, then I think there's a temptation to think, well, you know, if we take it on and we can't do anything anyway, then what's the point? And yeah, I mean, I think, I mean, the cases that you're talking about are very difficult cases, and there's no question about that. You know, I mean, I've seen some of those cases where they do come to safeguarding, and then you think this person needs housing, but the fact that the case is under safe, I mean, a local authority social services department still is not going to pay for housing unless somebody needs to go to a care home, and then it's not technically it's not a tenancy. So, you know, it's still yeah, it's really interesting. I'd like to hear more about, you know, some of those perceived barriers that people feel, because I think there are some of those barriers are real, and that's why, you know, that's why these cases don't necessarily go to these processes, because they actually it wouldn't actually necessarily solve anything even if they did go through safeguarding.
Juliet, can I just respond to that quickly? I mean, I think
Yeah.
you've described, you know, you've described something that came up a lot in the interviews. But the thing is, the critique of that other social workers reflected on is because post the Care Act, there hasn't really been the shift in thinking and in service provision and commissioning that perhaps should have taken place. So there's still thinking in terms of, well, we commission services for older people or possibly people with mental health or physical health needs. So actually what you're talking about is we can't do something because we're not commissioning enough. They do exist, but there are very few care homes for people who would be defined as experiencing multiple exclusion homelessness, who often have a real complexity of needs and are still drinking or using drugs and need that managed. There are not enough home care services that are prepared to work with this client group. It's not that social care would be expected to pay for housing, but they would be expected to pay for the social care support, and there often isn't the joint commissioning between housing and social care of the appropriate support. So what we've got is a failure in commissioning, and it is the local authority's job to scan the needs of its population and commission accordingly. But because things aren't logged, we haven't got the explicit data. And going back to the last presentation about what do you measure, if people are presuming we don't have a service, they're not going out to do the assessments which show that there are needs which are unmet, which would then have to be addressed by commissioning a service. And this is about shifting expectations of policymakers, funders, and commissioners, is that these are unmet needs.
Yeah, no, but that would be great if that could happen. Yeah.
Great. So we're slightly over. I think Victoria had written something in the chat, but maybe just because it's past the time when we were supposed to stop, only just, but perhaps you could pick that up afterwards. But yeah, I'd like to thank you, Jess. That was a great presentation, really, really interesting. I think it's probably the issue sort of persists as well in other areas too. I mean, I think we've kind of come across it in sort of just services around poverty as well. Just again, sort of sit outside of the scope really of what a local authority does within adult social care or can do with regards to, thinks it can do with regards to the Care Act. So yeah, I think there's lots of issues there that are raised by this presentation. So thank you very much.